Hello, and thank you for joining us for what I hope will be an interesting and informative discussion around some of the latest data in rheumatology. My name is Professor Peter Nash from the Griffith University in beautiful downtown Brisbane, and today we have the pleasure to welcome back Professor Roy Fleischmann, who's a clinical professor of medicine at the University of Texas Southwestern Medical Center. Welcome, Roy, and we do appreciate so much you giving up your time. Last time we spoke a little bit about oral surveillance and the data with tofacitinib. And today we're going to focus on another JAK, upadacitinib, and discuss your recently published paper, which looked at the long-term safety of upadacitinib versus adalimumab in the Select Compare study in rheumatoid arthritis that's recently been published. So Roy, can you tell us a little bit about, just before we dive in, has the JAK space changed since oral surveillance? Has UPA been used more than ever and TOFA less than before? What's been going on in the US?
Yeah, I'm not sure I know the answer to that question, Peter. In my mind, the safety signals that we saw with tofacitinib, as small as they were, are probably JAK specific and not just TOFA specific. But I'm not sure that most rheumatologists realize that. So my guess is that there is probably more upadacitinib being used than tofacitinib.
Okay, so, and in our country, they're quite a significant portion of the market. In the US, are the JAKs very popular, or are they being pushed TNFIR?
Well, according to the change in the product label as of December, you shouldn't start a JAK until a patient has failed the TNF.
Right. Even in the monotherapy space, even where there's some issue with TNFs, is there a caveat?
No, there is no caveat. That's one of the problems with how the FDA changed the label. What do you do with monotherapy, where a TNF monotherapy, as you know, is really not as effective as the TNF in combination with methotrexate? And that really is a space for the JAKs or for IL-6 inhibitors.
And not that it's very relevant, but have you heard of any litigation yet in the litigious US where patient on Xeljanz for many years gets a malignancy or infarct, they turn around and sue the rheuma? None of that's been going on yet?
I haven't heard of any of that going on yet. I think it's a little early for that. You know, the lawyers usually wait a little bit, and then they collect cases and cases and cases, and they take class action. And that's usually, you know, after a while. My guess is after a year or two, but who knows with lawyers?
That's true. And do you think there's any wriggle room to change the FDA decision, which is the whole JAK class and every indication? Do you think that'll soften over time or relax over time?
The FDA is not known for its flexibility.
Okay, so that's the answer to that question. Now let's talk about the study. What do you make, and how should the clinical rheumo think of these 3-year, 4-year, 5-year safety studies? Where do you think they sit in what we should weigh up as evidence when we're treating our patients?
Well, when you're taking a look at 3, 4, 5-year studies, usually looking for safety signals, because patients who are in the trials, generally in the phase 3 trial, in the double-blind trial, those who've had an adverse event to those who have not had efficacy usually leave the trials before the long-term extension occurs. This study is a little bit different because patients who didn't respond to one of the 2 drugs was switched to the other. And there were patients on both sides who had efficacy where they didn't have efficacy with the original drug. So it is a little unusual in terms of clinical trial design, but we can look at efficacy over time because of that reason. As well as
excellent. Excellent. So we should always check the retention rate over time and just see how many dropouts have occurred. And can you tell us a bit about how this study was done? You could argue that having a TNF arm is a little oral surveillance like out to 3 years, and that maybe if there are enough numbers, we could actually do a separate little study of the people over 50 with a cardiovascular risk factor and compare the JAK with the TNF.
You had a lot of maybes and possibly, and we'll see. So the difference is, yes, this is a study that did look at upadacitinib plus methotrexate versus adalimumab plus methotrexate over time. And this is a 10-year study, as you know. We just reported the 3-year at this point. So you could take a look at the safety signals, but as you pointed out, there are too few patients in this study to really see these signals. If you remember in oral surveillance, the point that I made was the incident rate of MACE and malignancy and VTE was extremely low. You need lots of patients for a long period of time to get events. And this trial, which has 300 patients in an arm, is very different than the studies that had 5,000 patients going on for 5, 6, 7 years. So we didn't see any of those events, actually. There was no difference between adalimumab and upadacitinib in this study. But again, this study was not the high-risk population. These are just patients on stable background methotrexate who randomized either to upadacitinib 15 milligrams plus the methotrexate or adalimumab. In the double-blind portion, there was also placebo. And if they didn't have an insufficient response by week 26, which we defined as in the beginning of the study, not having a 20% decrease in tender swollen joints, but at week 26 by not having CDI low disease activity, then they were switched. So and then they continue that way for 10 years, for a total of 10 years. And so there aren't that many patients, and the patients were not selected based on cardiovascular risks. So this is a general RA population. And as you know very well, when you take a look at the general RA population, and whether you take a look at registries or whether you take a look at insurance claim data, these signals don't occur. It only occurred in this very, very special population and in a very special group in this population. And that was not the population that was studied in this study. We did look in this study, and there were a few patients who actually would have qualified for oral surveillance, but we didn't see events.
Excellent. So the findings then, what we understand the select compare trial, very important, really powered for head-to-head at some of the measures. What were your safety signals that popped up? Anything that we should be aware of, such as the CPK issue?
Yeah, so let me go through that. So the safety profile was generally similar to adalimumab for adverse events of special interest. So that includes malignancies, major adverse cardiovascular events, or MACE, VTEs, and deaths. But upadacitinib, being a JAK, continued to show consistently better clinical response compared to adalimumab, as we showed in the beginning of the trial, including rates of remission, low disease activity. But there were safety events that did occur, and they were higher levels of CPK, herpes zoster, lymphopenia, LFT elevation. Those were the adverse events that we associate with JAKs, and they showed in this trial as well.
Any thoughts on mechanism for the CPK elevation? And generally, we don't even measure it, even though we know it can go up. We've come across occasional case reports of myalgia, no rhabdomyolysis. Why does CK go up, Roy?
Yeah, so you just made the important point. Don't measure it because you don't want to see the result if it's high, right? So there are no reports that I'm aware of patients developing frank myositis with a JAK. One of the reasons that I've seen postulated, which makes sense, is that rheumatoid arthritis patients you have an intense inflammatory burden, and they don't get around very well, and they have muscle atrophy. And when they are treated with an agent that really helps the inflammation, then the muscles begin to regenerate, and that can produce an elevated CPK. So that makes a lot of sense to me. The problem is that it would be the same with the TNF, right? A patient with active rheumatoid arthritis treated with adalimumab, many of those patients do well, and you don't see an elevated CPK. So I'm not really sure that that is the reason. That's what's been postulated, but in my mind, it's a little illogical.
Okay, so the zoster thing we expect with all JAKs, and I suppose we just have to be cognizant of vaccination. And you've got Shingrix over there. We've just got it here, but it's not reimbursed by our government. But what do you do with vaccination with your patients, Roy? Do you try and get them vaccinated even at the methotrexate level?
Yes. So, herpes zoster occurs in patients with rheumatoid arthritis, higher than the general population. And it does occur even when patients are on any background medication, whether it be any conventional synthetic or a TNF. It occurs a little bit more frequently with the JAK, as you note. So my thought is that any patient with rheumatoid arthritis that I'm going to treat should be treated with Shingrix.
Okay. Tell us about the lymphocytes. Early TOFA studies, it wasn't just lymphocytes that went down, it was NK cells. There was some question of whether that was associated with opportunist infection. Any thoughts on the lymphocyte changes, Roy?
So there are lymphocyte changes, but I'm not exactly sure about this, but I have a feeling that the lymphocyte changes are not NK cells with upadacitinib. I think that's one of the differences of being a more selective JAK1. I'm not 100% sure about that, but I think that that's true.
Okay, and the liver test abnormalities, do you think it's because of background methotrexate as much as the IL-6 inhibition?
Well, we know, yeah. So we know. So I've done a number of studies with JAKs, as you know, including monotherapy. And with monotherapy, the liver test elevation, really isn't as frequent or as high as it is in combination. So I think that there is some effect on the liver on the JAKs. But most of it, I think, is actually the background medication, whether it be methotrexate or leflunomide.
And again, the incidence of VTE MACE was very small. There's a very small numerical difference in non-melanoma skin cancer. We're very cognizant of that over here. So we do skin checks every year. Do you think there's any general advice about the skin for rheumatoid patients on all these drugs, really?
Well, actually, I think that you do it better than we do it, because you're exactly right. So there is a small increase in non-melanoma skin cancer, and patients should be examined every year. And I'd like to say that I do that with all my patients, refer them to a dermatologist for a full evaluation. But if I say that, I'd be lying, because I don't think about it all the time.
Right.
But I should, because we have the same climate you do. We have a lot of sun. From late March, April through October. So it really is something that we should do.
So we've had a good look at safety. What about the efficacy, and what about the switch data?
So on the switch data, the patients who did respond to adalimumab, many of them did respond to upadacitinib and vice versa. What's interesting is in Select Compare, which the initial study, the responses were statistically significantly better with upadacitinib versus adalimumab. And these responses actually were consistent as time went on. So patients still did well with adalimumab, but they didn't do quite as well, or in a group of patients, they didn't do quite as well as the patients on upadacitinib. there were more patients who achieved low disease activity and remission on upadacitinib versus adalimumab, although many patients did.
And it was nice to be able to switch without a washout and have no safety signal for doing that. So that's helpful for the clinician. You had some X-ray progression data as well. Anything new on the imaging side?
No, there's nothing new. So we know that upadacitinib inhibits radiographic progression. We know that adalimumab inhibits radiographic progression, and that's been fairly consistent through the trial.
So we're going to continue to see this stretched out over a number of years. Any take-home messages for the clinician as far as adalimumab on background methotrexate compared to upadacitinib on background methotrexate?
Yeah, so the statement that would make is, we have 20 years of experience with TNF inhibitors with adalimumab. Actually, we have 20 years. It was approved in 2002, a little bit more with etanercept. So the TNF inhibitors are really quite good, particularly in combination with methotrexate. The JAK inhibitors are actually a little bit better. So when we've done trials comparing the TNF to methotrexate, so TNF monotherapy to methotrexate monotherapy, the TNFs are no better than methotrexate. But when we do that with the JAKs, and we've done that with each of the JAKs are superior to methotrexate. So that tells you a little bit. And the studies that have been done comparing the JAKs to the TNF on background methotrexate, the study with upadacitinib, the select compare that we're talking about now, did show a statistical difference head-to-head with superiority for upadacitinib. Baricitinib, again, showed superiority head-to-head, and with tofacitinib, it was non-inferior. So my thought about this is if you could start a JAK, if you have a patient who is an incomplete responder to methotrexate or no response to methotrexate, and you can start a TNF or a JAK, my thought is that I would prefer to start the JAK. And the reason for that, the number needed to treat is about 10 to 12. So you have to, treat 10, 12 more patients to get one more result with the JAK. But the safety signal, the number needed to harm is in the hundreds. So the relative risk-benefit ratio does favor the JAK. So if I had rheumatoid arthritis and if I were allowed, I would start a JAK before a TNF. But in the United States, that's not the rule. The rule is we have to start a TNF prior to a JAK.
Okay, well, thank you very much for your time and trouble, Roy. We've enjoyed talking with you as always. If you want to hear more about this, and you can get detailed slide sets and you can get a summary of our discussions, you can upload, all of these are uploaded to CSF website this month. You can get the publication section at cytokinesignaling.com. Please subscribe to this podcast on iTunes or wherever else you get your podcasts. Give us some feedback, let us know what you think. We greatly appreciate it. And we greatly appreciate your time, Roy. Thank you so much.
You're welcome, Peter.
Look forward to seeing you in Copenhagen.
Yeah, it'll be the first time in 2 years?
That's right.